viewers, dear listeners, welcome to a very special episode of Faces of Digital Health. We're in San Diego at NextMed Health, a 4-day event, and Gary Monk here. It's a great pleasure to be doing this with you here. So let's reflect on what's been going on in the last 3 days, starting with day 1, when the focus was on AI. What were your key takeaways?
Yeah, great to see Anthony Chang, and I think hard to sum it up, but the key thing is how AI is moving from more of a, I guess, like an expert source of reference to, I guess they call it agentic, that it's actually going to be able to have so much power to be multiple different consultants, specialties to support patients, to support doctors. So we're going to see that level of control and power increase rapidly, and I think we're seeing that already.
We heard a very mind-blowing story from...
Mind-blowing sounds brilliant.
Stephen Brown, who was diagnosed with multiple myeloma, but very late. So basically, the doctors did all the tests they could, didn't find anything. A month after, he appeared in the ER because of abdominal pain. And that's when they basically discovered what his real problem was. And he then started thinking, would the AI discover this faster? And he built this whole agentic system. And I did a short interview with him, so let's hear that now.
So I had been having some abdominal discomfort, and I lost like 20 pounds and felt like something was going on. So I went to the doctor to get everything tested, full body scan, colonoscopy, endoscopy, and every blood test they would allow me to check the boxes for, or that they would check the boxes for, just because I wanted to find out. Mm-hmm. And the doctors thought it was a fishing expedition and couldn't find anything. So in the end, our house was burned down in the Palisades fire in Los Angeles, and we were displaced from LA and from our doctors, and I ended up in Palm Springs area and ended up in the emergency room for what I thought was something completely unrelated, and got some additional tests, and they sort of pieced things together and got to a diagnosis of a plasma cell disorder related to multiple myeloma.
What did you do then? Like, how did that make you feel?
Well, that was, on one hand, it's kind of a relief to actually have an answer. It wasn't really the answer I wanted to have. And then I was admitted to the hospital so they could do more biopsies and tests and sort of figure it out. And while I was in the hospital for, I guess, 9 days, I started using AI. I've done a lot of work in AI. I've developed a lot of applications with AI, and I've developed a lot of AI applications in other fields, and education and entertainment, so I've had a lot of experience in there. So I've been working with AI. So the first thing I went to is, my question was, well, you just figured out this now, but I got tested for all this kind of stuff just 3 or 4 weeks ago. When would the AI have figured this out? So I started testing on my own data, and kind of working with AI, but testing on my own data, and realizing that the AI would have figured it out earlier, where my doctors didn't. The AI can see patterns that people have a hard time seeing, because we know what we look for, we know what we're specialized in, and we have a fairly narrow field of view. Even when we think we know a lot, the medical field is very large and complex, and it's really not possible for one human brain to capture all of that. So it's very difficult, but AI has read all of the literature, and it has a much broader perspective.
And which tools did you use? So how did you go about this? Many patients in the room, or just like all the participants, started wondering, like, where can I get this tool? Because you also demonstrated your solution. Right. But did you start with ChatGPT? Like, how did you design everything?
Well, initially the exploration was just how good is the medical knowledge in the existing models, in the latest Anthropic model, in the latest OpenAI model, in the latest Gemini model. Just how deep does the knowledge go? So the first exploration with almost everything I do is like, what does it already know? But I'm building applications on top of that, because it's one thing to just have a conversation with ChatGPT, which is kind of designed to be a little bit different every time that you have a conversation. It's designed to be to have some kind of unpredictability and variability so that it's interesting. But if you're developing an application, you really need to kind of control and manage the whole process. So once I saw that the knowledge was in there, and in there in a way that gave me confidence that it was solid. I mean, you can ask AI questions and it will make something up. I mean, the most human thing that AI does is make stuff up. When asked a question, it will always give you an answer. That doesn't mean it's necessarily correct. And that's just inherent in the design of just how a neural network works. It's going to give you an answer, but the question is, can you trust it? So the first exploration is to probe the models for the knowledge and kind of QA them, as much as you can. Can I trust the knowledge that's in there? How deep does it go? What does it know? What does it not know? What are the limits? What has it been trained on? So once I saw that it had been trained on the things that were, the first check was, how well is it trained on medicine? And it's pretty clear that the leading models have already been trained on lots and lots of medical literature and information. So you can see that the knowledge is in there. The question then is, how can you, I'd say, reliably get the right knowledge out based on what your situation is, what the context is. So then I started kind of cross-referencing with my own data and some of the own particulars and digging deeper and deeper and deeper. And once I saw that it gave me confidence that the training is pretty solid, and of course it's getting better every day, I started building an application on top of it. And the application on top of it is partly to I don't say guardrail, but to make sure that it stays within the task that you're seeking, that it kind of doesn't wander out of the area, the zone of the model that you're trying to probe, and then also personalize it with your own questions and with your own data.
What surprised you, when you were building this out? Did you test different large language models? How did you decide that what you built is good enough? How much refinement did you have to make? Even in the beginning, when you said that you cleaned the data, did you mean that you cleaned the data, from your medical records? And how did you know what you have to do, given that you personally do not have a medical background?
Well, you can export your data from MyChart, and they're PDFs. And they're PDFs with a lot of other information in there, and tables and different kind of formats. And the question is it understanding what's in the PDF? So when I say cleaning the data, it's really more a matter of making sure that when you convert that PDF to plain text information, that it's a 1-to-1, 100% match, that it didn't mix something up or didn't miss something. So it's more a matter of understanding the data in the chart and making sure that it accurately understood what was in there. Because sometimes it's like, some of the things look like a faxed in report. Well, so it's like you need optical character recognition. You need to make sure that what comes out is structured data, that it's reliable, that represents what actually happens. So in the end, it's a bunch of medical test data, and it's a bunch of imaging reads of imaging, and then there's sort of the patient's symptoms and kind of chief complaint. So it's all the same stuff that the doctor is looking at. I just want to make sure that it's translated into a kind of a plain text format that the AI is going to understand. Because the AI is operating on plain text. Even when you upload a document or a PDF or an image, it's converting that into a plain text interpretation. So you need to make sure that it captured the right data. So that's partly, make sure that your inputs are correct. And as far as which model, in everything that I've been doing in education and entertainment, the model is interchangeable. I mean, basically it's a setting. You can choose any one of a dozen different models. So you choose. And the reason I do that is because the models are always changing. It was GPT 4.0, and then it's GPT 4.5. It's Gemini 1.5, and now it's Gemini 2.5. And these are getting better every day, and sometimes one is better than the other, and then somebody else comes out and it's better. And so I'm actually testing the models against each other. Mm-hmm. So I ran an analysis where on stage where I had multiple different doctors, which are basically multiple different perspectives, multiple different routes of navigating through the knowledge that's in the large language model. But I also can run the analysis of like, hey, same doctor, but 7 different models, and see what comes out. So part of that is, it also answers your question to when does this get released? Right now, this is an R&D phase because I am testing model versus model, navigation strategy or specialist versus specialist. And so there's still a lot of more testing, and I'm happy to do that on my own data or with volunteers who understand where this is at. Mm-hmm. But this needs to be something that we can count on for our own kind of decision support, with the right caveats and the right understanding that this isn't perfect. Is generating ideas. It's generating ideas that maybe you should talk to your doctor about. So there's a lot of that. It's helping educate you, helping you learn the language related to your condition, helping you know what things mean, and helping you talk to your doctor.
Do you use AI, Gary? Have you ever considered using it for health purposes?
For health purposes, yeah, I have used it in terms of looking up specific symptoms, trying to stay well, what sort of things are going on, what could they be caused by. I think I did a blog post about some side effects I got, which I thought from a medication. Without going into a lot of detail here, some muscular pain, was it to do with sport, medication? So I put that into AI. But I think what for me was really powerful was this opportunity to put all my health data, health records, even if now, I think it was Eric Topol said things aren't centralized, being able to throw in whether it's PDFs from my medical records, etc., and then get more of a holistic view of my health and all previous, I guess, longitudinal tests and blood tests and what that could mean in the future. So I think that's super powerful. Rather than just taking this moment in time, what's wrong with me, what can I optimize, to looking at my whole sort of history and how that might affect the future.
Yeah, that's the personal side. As we mentioned earlier, Anthony Chang had a 3-hour workshop on AI, which focused basically on how healthcare systems can adopt technology, or the challenge with the lack of knowledge among physicians and the challenge with upskilling. So let's hear it from Anthony Chang on the key insights from the workshop and why he is more concerned about AI not being used effectively rather than the dangers of AI. Mr. Chang, you just had a really engaging session on AI in healthcare, and I think one of the strongest points that you made is that it's soon going to be unethical to not use AI in healthcare. Can you maybe expand on that a little bit?
Well, of course, that statement has to be interpreted correctly. I just mean in certain situations in which there are cases that have used AI for quite some time and proven to be effective, that we are reaching a point in which the standard of care mandates that you use AI in a timely fashion to make the correct diagnosis.
Mm-hmm. Radiology is probably the prime example.
The one that I'm seeing some activity in terms of people holding the hospital accountable would be radiology, particularly brain scans and probably cardiac scans as well.
Mm-hmm. Another thing that you also mentioned is that sometimes you consult hospitals around their AI approach, and it's not that rare that if you ask, can you show me your AI strategy, that the strategy actually isn't there. So what's your advice to hospital leaders in terms of how to approach that? What if they already have a data strategy and a data governance strategy? What's the key thing that's usually missing? And what's your advice on where to even begin?
Yeah, my comment was that oftentimes when we get asked to talk to a hospital about their AI strategy, they don't even have a data strategy or data governance yet. So I think you start with a foundation, which is the data governance, and then you build on top of that an AI strategy or governance and also a committee. So it's something I said during the talk, which is AI agenda in healthcare has to be driven by human-to-human interactions and relationships.
And also that change is not technology driven, it's human driven. I thought
exactly
that was
right.
one of the better ones as well. So
And I think it's one of the beautiful things about AI in healthcare is the technology is pretty robust and mature right now, but it does take humans to learn about it, to adopt it, and to use it effectively.
where do you see the biggest danger of AI at the moment? One of the participants mentioned the fear of, the data sets that are not diverse enough, which doesn't seem that is going to improve in the future. So her call to action was for people to gather as much data as possible. So how do you see that development and basically the biggest challenges that AI is going to face before it's more broadly distributed?
Well, I think AI is going to hold us accountable to make sure that the data sets are balanced and there are technological workarounds that we can do, like use of synthetic data that's effective. I'm actually much more concerned about the mature AI tools not being used efficiently and effectively to help mitigate the burden that the caretakers have, as well as the disease burden that we have in general.
Where do you see the reasons why the tools are not used effectively? And which reminds me that you mentioned that basically out of the 4.2 trillion US dollars that's used in healthcare, basically 25% could be reduced with the use of AI in administrative tasks. So why is this not happening?
Well, I think the one reason is that not enough people are educated in this area, which we're trying to solve here partly, and the other reason is, and there are many reasons, but one of the other reasons is that the financial incentives are not aligned between the payers and the providers and the hospitals and the patients. So it's, having an AI as an elegant solution can't solve the human-driven problems, which is alignment of the financial incentives.
Is there anything that you think that people should currently know about Agentic AI, which was discussed at the end of the workshop? And you mentioned that it's often confused with AI agents.
Yeah. It's an easy thing to misunderstand or be confused about. I look at Agentic AI as a very capable captain of a team on the field. There's quite a bit of autonomy with the coach's direction, by the way, which is the generative AI part. So the Agentic AI would be the leader on the field with autonomy, and the individual players could be, we could draw the analogy that they're the AI agents, that they do things autonomously, but with the overall autonomy of the Agentic system.
So yeah, I think we should mention bias because Dr. Bayo talked about bias being really endemic within the health system. And we heard later in the conference about Biobank, I think Eric Topol mentioned it, that there's such a powerful resource, yet it's 95% white people. So a great resource, but I've got to say, it sounds inherently biased to me as well. It seems like it's a great resource that's actually fueling bias.
Yeah, it was a heartbreaking story of Dr. Bayo, who almost died in her own hospital during labor because her pain was dismissed as a black woman, despite the fact that she's a medical director in that institution. But she's a ray of sunshine. I think so. A very optimistic person. So despite that experience, here's some of her things that she believes that we can all do when we try to advocate for ourselves in the healthcare system, and when we try to contribute to basically decreasing the bias.
Okay.
And bias is something that we all have, and in my situation, it really is reflective that what happened to me can happen to anyone. And when we look at the statistic that Black women are dying at the highest rate during childbirth, I'm reflective of that statistic, and I had to advocate for myself. And what happened was, there were multiple areas of dismissal that happened, not only based on I'm a woman of color, and the fact that although I said something is wrong, I still wasn't heard. So it's my race, it's my gender, it's just all of the things that encompass who I am that unfortunately almost cost me my life even when I was advocating for myself. And I share my full story on my TEDx titled Do No Harm. So I encourage everyone to take a look at that talk because it shares my story, it shares what happened, and it also helps you know more about what you can do if you face a similar situation. And that was my goal, is if I can save one life through sharing what happened to me, that's what it's about. Because in the end, yes, I'm a physician, but at that moment, I was a patient, and I faced something that many women face giving birth in this country, especially Black women.
If we expand on that a little bit, when you're a patient, you are in a bit of a subordinate position. It's a vulnerable position in the power dynamics. You're the vulnerable party, and it might be difficult to advocate for oneself. So any tips, any advice on how people can do that?
Yes. So the 3 tips that I love is the 3 C's: be clear, concise, and confident. Be clear about your situation and what's happening. Be concise, meaning when you see the doctor and you feel dismissed or you're trying to share your symptoms, instead of saying, well, I've been feeling like this for a couple of weeks, say, I've been feeling like this for 1 week and it is impacting my quality of life. Specifically, I'm not able to get out of bed. I'm not able to spend time with my kids. And then be confident in the fact that you know your body best. So those 3 C's can really help you every time you go to the doctor, and just being clear, concise, and confident. And those are things that you can carry with you.
Everything we mentioned so far, Gary, was just day 1. Really intense program. Day 2 was, to me, very focused on lifespan, health span, women's health. What did you get out of that?
Yeah, it was. I felt the longevity came out, and I think it was Maddie, I can't pronounce the surname, Dykewald, talked a lot about longevity from a female perspective, but I think there were lessons that we could all learn in terms of healthy lifestyle, healthy aging, extending our lifespan. Key takeout for me was the fact that often it feels like we're getting older on this conveyor belt towards sickness, things we can't avoid, whereas actually we have a lot of power. There's a lot of opportunities to stay well, to stay healthy, to avoid some of the pitfalls of aging and have that longer, healthier lifespan. So I felt that was very, very empowering and positive.
A lot of focus was also on women's health, which is a field that's very well under-researched. So I spoke with Jennifer Garrison, who also presented on the ovarian health, and let's hear why that is important and why we should not consider ovaries just as reproductive organs anymore.
My talk was about reframing women's health through the lens of ovarian function. And the reason for that is that in addition to being absolutely essential for reproduction, ovaries are sitting at the center of a complex signaling network that's kind of like Wi-Fi, and they're talking to a lot of different tissues in the female body, and what they're doing is promoting health. We don't understand a lot about those axes of communication, but it's, you can think of it like a symphony. You're probably at least mildly familiar with the idea that your menstrual cycle is set up by a conversation that happens between your brain, your pituitary, and your ovaries, right? So imagine that there's a conversation like that happens between your ovaries and your skin, or your ovaries and your bone, or your ovaries and pick an organ. And while we don't understand very much about the details of those chemical conversations, they really are important for overall health, no matter what your age is. So beyond fertility, beyond menopause, which are obviously two very important things that happen that are related to ovarian function or dysfunction, no matter what your age is, your ovaries and how they're working is really important for your overall health.
Mm-hmm. How did these findings come about? And what that makes me wonder is which other organs or body parts are also as mysterious and we don't potentially know much about when it comes to women's health.
Well, I guess we really don't know much about female physiology, full stop. Like, forget about ovaries. We just don't understand how female bodies work. And what we can infer about ovarian function is really what happens when either they're missing, right, when they're either removed through surgery for whatever reason, or when they're not working properly. And that basically gives us a sense for what they're doing normally. So we don't have a lot of studies. This is a place where we have a huge data gap, and that's part of why I was talking about the need for more research on women's health.
So how does research look like at the moment? Funding, as you mentioned, is a crucial problem. So what can you then do? I'm almost afraid to ask, what do you anticipate in terms of what's going to be possible to research, especially in the US with the current, changes that are happening in terms of the support to science?
Yeah, I mean, we're at a crisis moment right now for all of biomedical research. I think, women's health, the word woman, the word female, those are on the list of words that have been used to revoke funding, pull grants, this censorship that's happening, which is absolutely ridiculous. I think at the end of the day, science shouldn't be political, right? It shouldn't be political. I'm, as a woman, as a scientist, I believe that knowledge saves lives. And biomedical research, when we politicize science, when we weaponize research funding for political purposes rather than for the public good, that's bad for everybody. And so, I think we're just at a crucial moment where we have to decide, are we going to choose knowledge or ignorance? And, that's, right now, I think the state of science funding is really under attack in the US. So we're either going to lose a lot of really great scientists to other countries, or hopefully something will turn around soon.
Mm-hmm. Based on the last 8 years that you have been researching, women's health, what are you observing? What kind of progress do you see? Maybe even what surprised you during this time?
Yeah, it's been great. I mean, we started the global consortium 5 years ago. We started the center at the Buck Institute 6 years ago, and the progress has been really amazing. Like, even better than I could have hoped in terms of just the number of researchers and clinicians who've come into the field and the progress that's been made. So many studies have been published now around ovarian aging. It's, it went from like a niche area where there were maybe a dozen people in the world who were really focused on ovarian function outside of reproduction and menopause, to now there are hundreds of people, right? We have the 4th annual Reproductive Aging Conference coming up, which is the only international meeting in the space. And, we anticipate there will be 100 people or more there. And so there's a field now where there wasn't one before. So there's a critical mass of people who are devoting their attention to this problem. And the fact that we're working on developing this X Prize around women's health and ovarian function, that's going to bring a whole different group of thinkers and innovators to focus on this problem. And so hopefully, we can continue to accelerate progress. Yeah.
Gary, We covered a lot already.
Yes, a lot.
We haven't yet shared with the audience what Eric Topol was talking about on stage. The things that kind of stood out most to me were the things around longevity and what actually works today and what doesn't work. So let's hear it from him, directly from the stage.
As everyone knows, there's been intense interest in anti-aging interventions, from cellular reprogramming, partial epigenetic reprogramming to senolytics to you name it, it's a long list. That's interesting, but the real science of aging advances have not been from those interventions, which all have some serious potential side effects and don't have any human data yet that show that they really work. But the real is the ability to determine the clocks, the metrics of aging. Like I mentioned, the organ clocks, which is amazing work that's come out of Stanford, Tony Viscoria, and now replicated through the UK Biobank in several groups, that each of us at any point could have a tube of blood with up to 11,000 proteins in the plasma and say, this is your organ that's out of kilter, aging faster than everything else looks good. You have that with genomics, and then you add on other layers of data like the epigenetic clock of Horvath. Then you start to say, we have so much data on any given person, we can partition risk in the three major age-related diseases: heart, Alzheimer's, neurodegenerative, and cancer, like we've never done before. Used to be, you'd say, in fact, 23andMe really pushed for the polygenic risk score. And the problem with the polygenic risk score is, okay, you have a risk for, let's say, Alzheimer's, but when? Is it age 98 or is it age 68? It really didn't help that much. Now you can pinpoint percent of a person's risk, that is how high, and also say when. And all three of the diseases I've mentioned are diseases that take 20 years to incubate and finally clinically manifest. So if we can't work with 20-year run rate, with the kind of layers of data that we have now that are going to become widely available and inexpensive, with the factors that we know make a difference, then we are missing perhaps the greatest opportunity. Now, the key point is that you can't use all this data if you didn't have AI, the models of today, including those with reasoning. Because that's what really cracks the case, is when you go through all a person's data, and that includes things like set points in labs, whereby the labs are normal, but the AI picks up that the trend, along with all the other things in that person, are pointing to something. So the data is so rich that we have, or will have, and if we can't use that to prevent the big major age-related diseases, then there's something wrong with us. So that's why I'm so excited. The key is not just that you are at risk for one of these three major diseases, but it's pinpointing, when and which, and the details. And there's been breakthroughs in each of those three diseases. The p-tau219 and other plasma markers that are as good as a PET scan for amyloid buildup and tau protein aggregates. That's a huge difference. We never had anything like that for picking up risk. And when you have two of those, you can define the arc of potential neurodegenerative disease. And of course, what's great is it responds to exercise and lifestyle factors. So, you get it, you have a potential burden integrated with all your other data, and you can take action. The same thing for cancer. We didn't have multi-cancer early detection tests that were worth much. Now we do, but they're being used on the wrong people. They're being used on anybody who's over age 50, which is completely stupid. But when they're used for people who are high risk for cancer, as a screen, on a periodic basis, that's when we nip this at the microscopic stage, and we shouldn't be doing total body MRIs. So another reason to do the book was, Peter Attia's Outlive book was very popular. How many of you read that book here? Yeah. One of the most popular books in this space for many years. And many things in there were just absolutely wrong. He had some good parts, really good on metabolic syndrome and that, but He advocated taking rapamycin. He advocated everyone should have a total body MRI, and many other things. He has a company, Biograph. And by the way, any person or company that's selling supplements is off the list for me, okay? Because none of these supplements have shown benefit for the health. Take it off the list.
That belies a sort of dark belly of longevity, right? All this sort of snake oil in a sense, go to certain countries and get a stem cell therapy. I'm a stem cell biologist and bone marrow transplanter. We've done stem cell transplants for a long time, and there may be some applications. How do you help, I mean, your book addresses some of this, sift through that noise and find ones that are real?
Yeah. Well, I mean, it's funny you mentioned snake oil. The most extreme form of this is this Brian Johnson guy. And he even has all these products, longevity mix. He has a product called snake oil. I mean, it's incredible. You can't make this stuff up. I mean, yeah. So how do you, I recently did a Substack on 12 companies that are basically selling longevity and health span, right? One of them, Function Health, Mark Hyman. I mean, he's a very bright fellow, and Function Health is valued at $2.6 billion. For what? They basically are testing several hundred lab tests and giving you, some counsel on that. The point about these companies, they have the right idea. We do need more data in individuals, but they're not even getting the right data. So I do think that's where we're headed, is deep data and using AI. It's funny, if you look at some of these companies, they say they're using AI, but they're not. I mean, not the AI that we know of. So we're moving in the right direction, perhaps jumping the gun in some of these companies. I think they have good intentions generally, but they're not up to speed.
Slowly, I'm gonna have to go to the airport, so we're gonna have to wrap up. To conclude our whole, reflection on NextMed, is there anything else that you would like to add? We just heard from Ray Kurzweil on day 4. What do you remember from his talk?
A couple of things really stood out. One was this idea, I think he said by 2035 we'll be able to do all drug research computationally, no need for, I guess, animal testing, even human testing, all be able to be done in silico. And the fact that we're getting close to artificial general intelligence and the implication that's going to have for medicine. So yeah, a very, very profound talk. I'm definitely going to summarize that, but yeah.
Yes, so thank you for being on this journey with us, and for more insights, go to Gary's profile.
Yeah, I'll write more of this stuff up on LinkedIn. So yeah, make sure to follow me. I'll do some more. I'll write about Ray, some of the other takeouts and trends that have come out of NextMed.
And just before we conclude, I think it's fair to say congrats to Daniel, Shauna, and the team for again creating a magnificent event that is memorable, full of new knowledge, and is definitely gonna keep us thinking.
Yeah, for sure. Without them, wouldn't be possible, and so much work's gone into it. So it's been an amazing conference.
Gary, you're a comedian. Come on, give me a joke.
I can't
Health,
joke.
health. This is do a
Give
pun.
me, make me a.
Do a pun on health.
So give me what? Give me what? You want me to do you a pun?
On health.
A pun on health. Well, I don't know what to say. Well, wellness. It's the best I can do early in the morning without a coffee.
Aging.
Aging. I've got a pun about aging, but it's an old one. Give me another word. Give me another word.
Word. Oh my God! What about a difficult one? We have to walk because it works well if we walk. What about a pun? Immunome.
What? Immunome. I could do a pun about the immunome, but it might make me feel sick.